Good evening. Such an awesome response. Thank you for joining us tonight to listen to our speaker on the subject of a good death. First, let's begin with a prayer. Prayer for the protection of human life. Heavenly Father, Lord and Maker of all that is good, fill our hearts with joy before the wonders of your creation. Open our eyes to the presence of your beloved Son Jesus in all those we encounter, and especially in the weakest and most vulnerable among us. Where we see life threatened at its beginning or at its end, or by poverty and deprivation, inspire us with love and mercy, so that, empowered by your Holy Spirit, may we work together to defend human dignity. Help us to build a culture of life, a culture in which each and every person is loved and valued as your child, from conception to natural death, and in every circumstance of life. Amen. Mary, Mother of the Living, pray for us. Before we begin, I just want to ask you, if you have any questions, to put them in the question box, and then I will gather them up and I'll group them so that when they're all the same questions, I'll put those together, and so we don't repeat all the questions, because there'll be a Q&A at the end of the session. It is my utmost pleasure to introduce our presenter tonight, Sister Dr. Nuala Kenny. The title of the webinar is A Good Death, the Challenge for Christians Today, on a topic that is of great concern to all of us. Sister Dr. Kenny has a long resume filled with advisory positions, awards, and appointments, and author of 180 papers and 5 books. She is American-born, a sister of charity, pediatrician, educator, and physician ethicist. I'm certain Sister Kenny's presentation will educate and motivate us to promote palliative and hospice care and stop medical assistance in dying. Now let us listen to Sister Kenny.
Thank you very much. I'm always honored to have anything to do with the Catholic Women's League. I think over the years, and even in times when I was consulting with the federal government, the Catholic Women's League submissions were always considered to be well thought out, well documented, and well presented. And I was very happy and proud to be able to support any of that I could. So what I want to try and do tonight is to first say to you, look, I think the issue of hospice palliative care is a wonderful theme, and the CCCB Palliative Care Toolkit is an absolutely fantastic tool and source of information. So I'm not going to repeat what's there, except on a few points I'm going to try to reinforce some issues. Rather, what I want to do is to try and bring you insights on the magnitude of the challenge of a good death for Christians today, including the issue of hospice and palliative care. But it's the enormity of the situation that we find ourselves here in Canada. And Joline said, I'm an American by birth. I'm a Canadian by adoption. I'm a dual citizen. So I've lived and practiced my whole medical life here in Canada. So what I want to do is to give you some highlights of these foundational issues and teachings, because I think that will make you more understanding, more savvy, and as we move towards the end of my reflection, you'll see maybe even more politically effective in this incredibly important area of our lives. So my goals, remember I'm a university professor, so I got to tell you my goals. We're going to do 3 general things. The first is we're going to start where I believe everything should start for any of us, disciples of Jesus Christ, when we come together to work on any project. We first reflect on Jesus. And when we talk about the issue of suffering and death, I mean, this is the central mystery. We're not that far. We've just, with Pentecost, just finished the amazing Easter season. So we're going to start with Jesus and some careful reflection that it is crucial for us to begin this session with. Then I'm going to move into the political arena, and I'm going to go back to the Supreme Court decision on they call it MAID, medical assistance in dying. The name is a total misnomer. Palliative and hospice care are medical aid in dying. Medically assisted death is medically assisted death, and we're going to see what that actually means. But we're going to try to understand what are the challenges and the ongoing challenges, because the legislation around that is still not over. We're still in process with that. And then you see, I want to identify the importance of three things. Again, this is all with the idea of creating the most careful, thoughtful approach that is so typical and has been so typical of the Catholic Women's League. So let's go. If we start then with Jesus, I love this line from Hebrews. For it is not as if we had a high priest who was incapable of feeling our weakness with us, but we have one who has been tempted in every way that we are, though he is without sin. This is my favorite. This is the image from the scripture where I know Jesus is real. He's human. He doesn't have a little God suit that he zips up and it just makes it look as if he's experiencing the pain and suffering. This is Jesus in Gethsemane, down on the ground. So let's just remember Gethsemane. He goes, he doesn't know exactly what's going to happen as he moves to Jerusalem. But he knows now that both the Jewish high priests and the Romans are terrified of him. So he knows it's going to be terrible. Whatever is happening is going to be terrible. He takes 3 of his pals. Remember this, because you never want to deal with difficult issues, especially issues of pain and suffering, without your friends. We need accompaniment. So he goes, he says to the 3 friends, you wait here, you pray here. I got to go up and talk to the Father. And what he does, it's interesting. Many people think that the way the scripture describes it, he goes up to the top of the little mountain to pray with the Father, and that he kneels and prostrates himself. Garbage. That's not what it is at all. If you look at the original Aramaic, and I've written beautiful reflections on this, he actually collapses at the thought of that something huge and horrible and maybe even death is going to happen. Can you identify with that? Horrible things happening. And what does he do? He gets down on the ground and he says, Father, I don't want to do this. I don't want to do this. I don't want to do this. This is real incarnation. God so loving us that he came to assume our vulnerability and take on our pain and suffering. So he goes up and down a couple of times, and what happens? The guys he brought to help him are sound asleep. They're so prostrate. They're prostrate, but with fear. They're not even. So he also experiences abandonment at the time when he needs support most. But then what happens? The third time, whatever happens that last time, so up and down, when he comes back down again, we're going to Jerusalem. And then what happens is he, in fact, does take up his cross. He, in fact, trusts that into your hands, Father, I commend my spirit. This is Jesus. This is the love of God made incarnate and real. No, nothing that we can suffer did he not experience. We can be assured of that. And because of his willingness to suffer, what we see next are these lines. O death, where is thy sting? O grave, where is thy victory? Look at 2 Timothy. Jesus has destroyed death and brought life and immortality through the gospel. The important thing here, life, when we say life is changed but not ended, we mean this. We mean this. And when we talk about a good death now and the challenges, remember, this is the essence of the Christian paschal mystery, Jesus suffering and salvific work for us. So as we move forward, I want you to look at this for a second. And when I've done public lectures on end of life stuff, I always say, when I show this picture, it's a Victorian picture. So, but before I show the picture, I say, now I'm going to really test out who are the good Catholics in the room. I'm going to ask, who's the patron of a good death? And of course, a whole bunch of people. Sorry, my dislocated arm. I have to raise my arm. Okay, a whole bunch of people put their arms up. But what I want you to do, don't be distracted by the Victorian dress. I want you to look at this image to evoke through imagery. What are the things that you see in this picture that would make for you elements of a good death? Just do this quietly to yourself. Just look carefully for a minute. Now, if we were together, we could share on this, but we have so much other stuff to do but I want you to think of this again later. What I see, first of all, it is a scene of sadness. Let's be very clear. Let's be very clear. Because we're Christians and we believe death is not, it doesn't mean that we don't have grief and sorrow at the loss of the person in our physical lives. We are human, we are connected. So there's a sadness. But the things that make this amazing are Joseph is surrounded by the two people he loves the most, Mary and Jesus. The two people he loves the most. What does that mean for a good death? The other thing that you see on Joseph's face, he's looking at Jesus, but look at his face. This is Joseph, who gets short shrift in scripture from my perspective. But this is a just man. This is a man who's dying in peace. I believe what it's conveying to me is Joseph knows that he's going to God, who will judge whether or not Joseph, fulfilled his obligation to Mary and to Jesus. And he's totally trusting he did the best he could. He did the best he could, and he's leaving it all now to God for judgment. And then I want you to look at one other little thing that always fascinates me. Look at Jesus and his left hand. This is important to me. Joseph is not grabbing Jesus. It's not Joseph depending on Jesus. This is Jesus, the Son, holding on to, connecting with, holding on to, physically with, and supporting the beloved Father on earth. So think of that and those elements, and ones you may think of, others that you see, And now we'll look at something that becomes the challenge to anything that we've just reflected on about Jesus's experience and the good death in the tradition of the Catholic Church. So next. So after years and years of legislation attempting to legislate medically assisted death, so I'm now using medically assisted death. MAID is the name of the legislative bill that legislated the Supreme Court decision, but the activity is medically assisted death, euthanasia and assisted suicide. So there had been years worth of legislation, of attempts at legislation. I worked with the CCCB, I can't tell you how many times. I even remember doing something with a group of CWLs. I was trying to remember it, but with the forgetfulness of aging, I don't completely remember it. But the point I want to make here is that for years, people, particularly as it began to happen in Europe, particularly in the Netherlands, and we saw countries there beginning to legalize this. And what then happened was the big case. Do you remember the name Sue Rodriguez? That was 1993. So this predates. Look, this, but it predates it. And with Sue Rodriguez, this is a woman. She had, a horrible disease. She had ALS, amyotrophic lateral sclerosis, one of the most painful and complicated deaths. It was a terrible disease. But she, in fact, wanted, as her disease progressed and she got more debilitated, while she was still competent, to request that she have her life ended. And that actually then began a new strategy that moved from legislative attempts, where every time we voted, we could influence lawmakers individually, and we never made the legislative attack. But the legal attack was instigated by a brilliant group of proponents. I know 2 or 3 of them personally, who are absolutely committed to having medically assisted death in this country, and they decided to go the judicial route. So in 2015, the Supreme Court of Canada, following a case that came from British Columbia, interestingly, Rodriguez was in British Columbia, but a case, 2 women in British Columbia, was appealed to the Supreme Court of Canada. And this is what the decision was, and then I'm going to show you the elements that we have to pay attention to. The Supreme Court of Canada decriminalized. This is not legislation, so this is because it's the Supreme Court. It can only make a judgment about law. It decriminalized medically assisted death for these 3 criteria. Very important. First, for competent adults, and hold that, we're going to come back to it, for competent adults with a grievous medical condition, including an illness, disease, or disability. Second, criteria that is irremediable, meaning cannot be relieved by means acceptable to the individual, and causes, and this is what it's all about, enduring suffering that is intolerable to the individual in the circumstances of his or her own condition. So as we see this, please note, it has nothing to do with dying. It has nothing to do with end of life. And it is about suffering. And as we unpack it next, we're going to see the Supreme Court decision was actually based on a challenge by the Charter of Rights and Freedoms. And as an American by birth, the the Charter of Bill of Rights came early in the formation of the American government, but the Charter of Rights and Freedoms actually was quite recent for Canada. We, 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 but once there was the Charter of Rights and Freedoms, the Supreme Court decision was based on that, and it ran this way, just so you understand how things have gone. It went this way. If I wanted to end my life because of an intolerable suffering to me, and I didn't even have to try treatments, it was just intolerable suffering to me, but I had a handicap or I had become mentally incompetent by the time those circumstances had occurred, then if I were able-bodied, I could do it. If I wasn't able-bodied, I required help to do it. I needed help to end my life. So it was not confined to terminal illness or dying. This, please understand. I mean, some of the cases that I've been involved in discussion and reflection. A 32-year-old young man with a traumatic car accident who went blind. He wanted to have his life ended because he didn't want to live blind. A competitive swimmer who, in fact, had a fractured pelvis and would never be able to do competitive swimming, and he was only 21. So it's not. The words terminal illness or dying are not in that legislation. It required, though, right away, an understanding of at least 3 issues that needed further study as we tried to legislate this. Mature minors. This wasn't little. These were children with major medical issues. Advanced directives. That is, you name the circumstances which, when they occur, then you want your life ended. But remember that a competent decision is the basis for the whole legislation. And then psychiatric illness as the sole condition. And again, we still have not resolved that. For political reasons, that's still on the bench. And of course, it's because most of psychiatric illnesses are precisely ones which disempower your ability to make free informed decisions. Now, further study, all of those things look in place. And what did we see promised? That the vulnerable would be protected, and that there would be protection of conscience for individual healthcare workers and institutions. That's what they promised. Now let's go to the next slide, because I'll show you that if you look at what happened since 2015, Bill C-14, Bill 7, B-39, Bill C, all of these were attempts to, in fact, regulate this. They even tried to add on reasonably foreseeable natural death. Quebec kicked that out right away, and so then did the feds. What has happened in our country is the rapid normalization of medically assisted death as death with dignity. A death with dignity is a controlled death. We're going to have a party at 2 o'clock. Mozart will be in the background. We'll be serving sherry, and then Nuala will be put to sleep. But it's been rapidly normalized, even by devout Catholics. I mean, Pew Trust studies have shown in Canada. I mean, some surveys have suggested up to 80% of even Catholics who are still going to church, that small number who are still going to church, in fact, think it's perfectly okay. Most important, the reality, in every area that was under study, it's been expanded. Every safeguard, wait time, second opinion, all of those have gone. And crucial for our understanding as Christians, profound inattention to protecting the vulnerable. So if we look then at the issue of some really important church teaching, I'm going to do this very rapidly, but you need to pay attention to this, because sometimes in our defense of our position against the medicalization of suffering, the medicalization of death, we Catholics can also get a little confused about what, in fact, church teaching is about. So I've just got a few, and these are all from the Catechism, or there's one from John Paul II. Life and physical health are precious gifts entrusted to us by God. Just watching my time. We must take reasonable care of them. Look at that, reasonable care of them, comma, taking into account the needs of others and the common good. That criteria is crucial. And the second, following right after it in the Catechism, if morality requires respect for the life of the body, and it does not make it an absolute value. So when you see and hear some of these strategies that some people thinking they're pro-life, but rabidly vitalist, kind of seizing babies and who are dying, but making the prolongation of biologic life the end. That's not the reason for our life is so that we can give interaction and prayer and thanksgiving to God. So the second area of teaching that becomes really important, and actually St. John Paul II said this beautifully in Evangelium Vitae, to forego extraordinary or disproportionate means. That was the language that we began to use. Is not the equivalent of suicide or euthanasia. Rather, it expresses acceptance of the human condition in the face of death. So again, this issue of trying to take into account the only person who can decide whether a medical benefit is a benefit that is worth it or a risk and harm that is not worth it is the person themselves. And that's justified in modern bioethics and in church teaching. And then the next teaching that I want to just make sure that we're very, very clear about, because this is something that's very crucial to me. Again, this is the Catechism. The use of painkillers to alleviate the suffering of the dying, even at the risk of shortening their days, can be morally in conformity with human dignity if death is not willed as either an end or a means, but only tolerated as foreseen and tolerated as inevitable. This is the principle of double effect. We intend to do this, but there may be, there's not a single drug that any of you take for anything, from the common cold to a headache, that doesn't have side effects. But the thing that's crucial here is sometimes Catholics have in fact deserved the claim that others make that because we're not supporting medically assisted death, we're the ones who are not compassionate. We're the ones who are causing suffering and not responding to it. No. We have an enormous obligation to do research, particularly in hospice and palliative care, but in other areas, to make sure that we do optimal pain control. And refusing treatment that's too risky for the individual is morally acceptable, as long as they take prudent care, reasonable care of their body. And then next, I think the next thing that we want to look at is this important issue in the next slide of the reasons people actually request medically assisted death. These are surveys where it's been legal, not legal. These go way back. It's been recently confirmed by a federal review, but we don't have time to look at that. First of all, what I just referred to, inadequate palliative care access and quality of care, inadequate pain and symptom control. I mean, if we're not doing as much as we can, even though we can't promise to cure all pain, to relieve all pain, but if we're not doing the optimal job, then people say, I want out. But the big reasons, again and again and again, that are important to us as Christians are issues of suffering. The feelings of loss of dignity, the feeling no child of God loses their dignity because they in fact are in a dependent care, even for intimate health care needs. Dependence and loss of control. I mean, in our modern world, control seems to be the only thing that matters. And yet vulnerability and dependence is what Jesus and the incarnation is about. Look at the third bullet. guilt at being a burden to others. This is a huge one. People who, in fact, have families that are trying to cope with them, particularly if there's no access to hospice and palliative care, trying to take care of them, trying to support them, and children, adult children, giving up their job to take care of mama dying at home. Huge issues. Guilt, isolation and loneliness, and then hopelessness and loss of meaning. So for the next slide, I want you to, again, just reflect on something very briefly, as then we move into the last few things I want to comment on here. So I created this little image, which I think is brilliant. It's one of my brilliant thoughts, because I was trying to get, it was a large lay group that I was speaking to. I wanted to find a way that could get them to ponder. I love that, huh? That's Mary. Ponder. To think deeply. Ponder the difference between pain and suffering. And my little mnemonic to help you think of it is, think of the difference between chest pain from a heart attack and heartache because your son is lost to drugs on the streets of Vancouver. You got it? Chest pain is physical. I mean, it brings with it a certain degree of suffering and distress. But my colleagues in medicine and diagnostic imaging and cardiology, and now there's robotic surgery for cardiac. I mean, we got lots of stuff we can do for you if it's chest pain. If you have heartache because your son is lost on the streets of Vancouver to drugs and violence, I'm sorry. There is no medical intervention. Now what we have to do is have to accompany within the mind of Christ and support. So, how do we do that in the world in which we find ourselves? And Samaritanus Bonus was a Congregation for the Doctrine of the Faith proclamation in 2020. It's the most recent one that's just talking about health-related issues. And it beautifully set up the cultural obstacles to the sacred value of every life. And it said, remember that the inherent dignity of all persons made in the image of God can never be lost. But in our world, the primacy of autonomy and choice means that anything else like compassion is not understood. Moreover, those who think that it's compassionate to end someone's life never even looked at the derivation of the word. If there are some English teachers in the audience, okay. Compassion. It's to suffer with. Again, the accompaniment, again, the support. And then look at the biggest issue that Samaritanus Bonus brought, which is the issue that for me is the most important thing. It's a medical, technological solution to a spiritual issue. Look, let's be very clear here, gang. In our world, we expect Botox to fix these lumps, and I don't know what I can do about that flappy thing there. But we look to technological solutions. When we're popping pills, we're taking pills to deal with our weight when we can't control our appetite. We look for medical technological solutions often to things that are what we call angst or spiritual related issues. So, as we're coming now to the time when you're going to have a little time for reflection, I want you to remember that palliative care, and this is from the Pontifical Academy for Life in March 2015, Pope Francis himself. Palliative care is an expression of the properly human attitude of taking care of one another, especially of those who suffer. It bears witness that the human person is always precious, even if marked by age and sickness, and is loved by God. When life becomes very fragile and the end of the earthly existence approaches, we feel the responsibility to assist and accompany the person in the best way, which is palliative care. Let's remember, too, that palliative care is a philosophy of care. It's not a place. It doesn't have to be in a place. It can happen in a palliative care unit. It can happen in a hospice, but it can happen as a philosophy of care in acute cardiac units, dementia units. The important philosophy is palliative care neither hastens nor prolongs death. It balances pain and symptom control with participation in what I call the last things, not the theological last thing. What are the most important last things? Goodbye, thank you, forgive me, I forgive you, do you love me? I mean, all those things that are the things that we need to complete in our relationships so that we can in fact go to God as Joseph did, knowing we did the best we closed off with the important persons in our lives. And palliative care here, now I'm saying again what I alluded to before, boy, do we ever have to have effective political advocacy. We need to expand palliative services, fund research in difficult end-of-life cases, and counter the cost effectiveness of the MAID legislation. I have a Canadian Medical Association Journal article on the cost effectiveness of MAID. Let's be clear about this. If you have someone who is in difficulty and now you in fact have a son or daughter saying, Mama, you don't have to suffer this, you do have this option, or the doctor coming and offering you the option when you didn't even consider it, and there's no adequate pain control, and nobody's encouraging the development of more palliative care or research in complicated cases, then medical assistance in death is cost effective. And we have to understand the power of all of those things as we look at our obligation to protect the vulnerable. So then as we come to now the questions I'm going to get you to reflect a little bit on, thinking always of accompaniment with the mind of Christ, understanding the church teaching as we've had it. I want to say something briefly about decision making. Remember, I'm alluding to this is supposed to be a competent decision. And then if we look at the requirements for decision making, the requirements for an informed choice are information that not that the doctor wants to tell that the patient needs, capacity or competence, that is to understand the consequences of the information and this choice and that choice, and freedom or voluntariness. Go back to guilt. If you are so guilt-ridden or so fearful about what's going to happen next, or guilt-ridden about the burden on your families, there's no way you can make a free choice. If you have no option, if there is no palliative care hospice unit anywhere near you, I mean, if you have no option, you have no choice. But as we look at all of this, all of us have to, in fact, recognize that the decision making has to fulfill these requirements, and we have to be careful in understanding, are the goals of care curative, or are the goals of care end of life palliative, or palliative at the beginning of a terminal illness? And then how do we make a decision? So the final advice before the questions for you. I'm sure every one of you has made a will, especially those of you who are older. Everybody should, I guess, have one if you have property and the like, children. But advanced care planning as a spiritual activity is something different. I've written about this. We put stuff on the diocesan website for Archdiocese of Halifax, Yarmouth. Advanced care planning as a spiritual activity does this. First, it asks you to reflect carefully on your beliefs, values, and hopes, both for care and in this environment for the funeral. both for care and the funeral. Remember, if you have medically assisted death, you cannot have a Catholic funeral. There can be a bereavement service for the persons who are left behind, but you cannot have a Catholic funeral because a funeral celebrates the life of a person who died in the faith. And it's against the faith. Advanced care planning requires clarifying beliefs and then conversations with everybody who needs to know what care you want and what kind of funeral you want. And then, for the time when you might not be able to decide for yourself, appoint a substitute decision maker, and this becomes crucial. It's the substitute decision maker has to give you the gift of deciding for you in the specific circumstances when you can't, as best he or she could, knowing what you want, not what they want. So a son or daughter who's all supportive of medically assisted death can't say, well, that's what we'll do now that mom is not. What, and that's where the conversations and the clarification of beliefs are important. So now my questions to you. I want you to reflect in the next little while, and Joline will give you some instructions here. I want you to reflect on what has been your experience of dying, young and old. Remember, I'm a pediatrician, though I just had my 80th birthday on Friday, May 17th. But I'm a pediatrician. I did pediatric palliative care for 34 years. Pediatric palliative care for 34 years. What's your experience of dying? Friends, family, loved ones, in work, etc. What is your experience of medically assisted death? Have you had friends or family, parishioners, who in fact wanted you to come to the party celebrating when the medically assisted death was performed? When you think about a good death and the context of our world today, what are your spiritual and practical concerns, and how do you believe the Catholic Women's League can make a difference? Think about it.
Hi, Sister. Jolene seems to be having a little trouble reconnecting, so shall I offer you the first question that was asked?
Sure, I'm here, ready to
You're ready to go. Okay.
ready to go.
Absolutely. The first question is, how should we respond when someone tells us they are going to use MAID?
Good. Okay, so I actually I have a lecture that I give to physicians, or I've given to physicians a number of times on this one. Now that was in the first few year or so after it was happening, and now that it's so rapidly normalized, I'm realizing more people need to have a sense. So this is the way. This is the way I'd answer you. Most of the time, individuals are asking, they're inquiring about MAID. In other words, they're expressing interest in it. If I wanted to think about this, what is it, and how would I be eligible? And so that's, you need to, that very first step. Historically, look, let's be clear. In the Hippocratic tradition, 200 years before the Christian era, so half was 400 years, the Hippocratic tradition, but 200 years before, there was a clear precept: thou shalt not give a deadly drug even when asked, even when requested. Throughout human history, people have said to doctors, can't you do something? But the answer when it was illegal, but it was also a different moral question. And when it was illegal, the good docs then it's what I call, they sat down and they leaned in. In other words, they They took it as a cry for some kind of help. And what they did was the very first thing that they did was to try and listen to why the patient was asking the question. The person was asking, sorry, Dr. Talk, I say person was asking the question. And as they attempted to get a sense of that, they were trying to recognize they needed to review pain and symptom control. They needed to review whether or not the person was being, in fact, given the information they needed. They needed to know whether or not anybody was helping support the family of the person who was there. So the traditional response was, it was kind of recognizing it as a cry for some kind of help and lean in. What we know in this day and age, the tendency is that people immediately go to the assumption that an expression of interest equals a desire and then a request. And those are different steps. And at each step, our response, I believe, and certainly the response of those of you who are not healthcare providers, I mean, that's when we do sit down, lean in, try to understand what's going on with the person, and attempt to see whether or not issues about loneliness have maybe they haven't not connected with faith at all. I mean, in hospitals in Halifax, they don't even ask your religious affiliation anymore. They can't do that. It's prejudice or something. I was just a patient myself, and you're crazy. I'm Sister Nuala Kenny. Of course, I'm a Roman Catholic, and I want the chaplain to know. So we've got a very funny kind of an environment, but friends, family can be attentive. Don't be judgmental. That was the person is trying to work something out. But I would also say to you that it is also important as persons move along to actually wanting to make a formal request. That's a different step. And I have, as a doctor and an individual, made it very clear that I personally, my moral and spiritual beliefs, as well as my medical ones, this is wrong. But that you accompany the person as best you can up until the really tough question. And I remember having dinner one night after a diocesan lecture out west with a fabulous, wonderful bishop. And he said, Sister Nuala, I just had someone who was a friend of mine, and I thought he was a devout Catholic, and he wanted me to be there when the maid was performed. And so then you said, what is this? Is that my standing with you at the very last, hoping for bedside conversion? Or am I there complicit with what's going on? So these are very, very difficult and complex questions. And I guess I would say, go back to Jesus, his compassionate response, and the way in which he would have responded to pain and suffering, the way he attempted to deal with, and accompany as best and as far as you can. Attempt to see if you can advocate for whatever might help them. But so I'm sorry, it's a long answer, but it's because it's such a difficult question. But for each and every one of us, we need to be able to recognize that there will be loved ones. I mean, as I said, some of you may actually have experienced that. And how do you process that, knowing that it is, in fact, is this medicalization of suffering? It's failing to believe in salvific suffering. Is that any help at all?
Absolutely, thank you. Joline, we just asked the first question while you were away.
Okay, I'm back. Another question for you, sister. How can we best advocate for and support our Catholic hospitals and hospice facilities?
Well, now there's an interesting question. Because in actual fact, right across the country, there are many places like Halifax where we have no Catholic hospital. I mean, I think remember I showed you Samaritanus Bonus, the most recent of the Congregation of the Doctrine of the Faith statements about care of the sick and dying. In that cultural kind of situation, it used to be, and go back to what I said about, remember the promise, the promise that we would protect the vulnerable, and the promise that we would protect conscience of individuals and institutions. Okay, so bring all of that together now here, because the fact of the matter is that right across the country, I mean, there are still some places that have a few Catholic hospitals, but this is not everywhere. And just as we're closing churches and closing parishes and losing, I mean, the issue of Catholic hospitals becomes an issue. More important, and this is part of the legal, the loss of all of the protective mechanisms here, is that even in palliative care units now, I mean, palliative care, the way, in fact, Dame Cecily Saunders, an Anglican nurse who wound up becoming a doctor, the foundress of the palliative care movement, it was to in a time with technical advances, it was to make sure that the dying were still cared for. I'm of an age, I still remember rounding as a medical student, and the patients who were dying on a ward, the pulmonary ward, cardiac ward, they were down at the end of the corridor, and sometimes you didn't even round on them because there was nothing you could do. So when it was a cure oriented, so the whole philosophy of palliative care was this other kind of response. So I think the issue of the, where we are today, doctors are now obliged to offer as a medic, because the medical standard has always been that when you're talking to a patient, you provide all reasonable options. Doesn't mean every million possibility, but now actually obliged to list medically assisted death as an option. So, and even in palliative care units, which you thought would have been the place that would be most protected. So we are at this very, very interesting, deeply problematic place in terms of respect for protection of conscience for individuals and for institutions. I want you to know, I have colleagues of mine still in clinical practice from Ranger. Most of my compatriots are older and retired, or my age and retired from clinical practice. But what we know is all of the doctors, including in belonging to groups that many of you would know, Catholic physicians, etc., who say, I could never become a physician today. Because first I couldn't pass the entrance questions because they would ask me if I would be willing to, against my personal beliefs, to perform medically assisted death, or would I make an effective referral? And if you said I couldn't do that, you wouldn't even get in. So their concerns are that we've changed this so much that it's a worry as to facilities and how well they protect. If you do have a Catholic hospital, I assure you, because I was the medical advisor for the Catholic Health Alliance of Canada after I retired from the university for 6 years, they're all grappling with this issue of needing to provide medically assisted death as an option. Some of you may know, if there's some of you maybe here from the Vancouver area, you know, wonderful St. Paul's Hospital, right? I mean, St. Paul's has been amazing, especially in care of drug addicted and vulnerable street people. But I mean, they actually, there was a test case against them because and a big newspaper coverage that they wouldn't provide medically assisted death, but were transferring patients out to a facility that would. And they were seen to be lacking in compassion. So the environment in which we find ourselves, very, very tough. That was not a helpful answer, because the situation where you have an institution, use it as best you can to help keep people aware of exactly what has happened here, particularly for the vulnerable. Jolene?
There. Thank you. Okay, just a couple more questions. One is about organ donation and wondering if that is readily offered. Would you, sister, would you be aware if they offer organ donation instead of MAID or?
You mean organ donation from a person who receives MAID?
Yeah, well,
Wait a minute.
yeah, good.
Yeah,
I'm
no.
not.
This is a very serious issue. There was an article. I still get the Canadian Medical Association Journal as a retired member. How long ago was it? Oh, it was before. It was maybe 5 months ago. Um, there was an article about the increase in organ donation from persons who, in fact, were opting for MAID. And this was very interesting article because what it was showing was that for some people whose life was now going to be ended in there, they wanted their suffering ended by this medical means, they could find meaning. I'm putting, how do you do the quotes thing? They felt that there was a certain meaning that they could find in what happened to them if they were able to give an organ to someone who could benefit from it after they were deceased. And of course, and they showed that there was an increase in organ donation. It's small, but beginning to be tracked from persons who have medically assisted death. Now, everybody here knows, I mean, giving an organ or receiving an organ is perfectly morally acceptable in the Catholic tradition. There's nothing that's a medical, it fits with any criteria for medical decision making. But the issue, Jolene, I think that the person is this issue of, it's, as I said, finding some kind of extra meaning in I gave this donation and then I passed on. It's a strange way to think of a legacy, but I guess that's maybe what it is in the minds of some people. Dangerous.
It is. Yes, that's what the person meant. They meant that people who die with me using MAID. Okay, just one more question. And there was also a comment. Somebody said that, Sister Nuala, in our 12 hours of prayer for palliative care, our council always prays your way of the cross, reflections on suffering and sickness and dying.
Oh, thank you. I love that. I did that ages ago for our diocese. Yeah.
It's lovely. Okay, one more question. I'm a registered social worker and I investigate potential abuse and neglect against vulnerable adults. I'm becoming quite interested in palliative care and want to practice from a holistic lens as spirituality is so important. Any advice, suggestions on where to seek professional training opportunities?
Oh God, darling, do I ever wish I did, but I don't. What a wonderful thing, though. Whoever that is, go for it. Go for it, girl. Go for it. Um, no, I don't. Sorry, I'm trying to think, and no, but I think that's because look, I mean, and I've just written something about the importance of social workers in developing a culture of safeguarding children and youth, doing my pediatric ethics side of things. But social workers, my God, gosh, you're right there, seeing vulnerability in the home, seeing, I mean, a phenomenal place for you to then be able to assess. Again, it's like to get ahead of the what are the fears, what are the hopes, what are the needs for accompaniment that the person has. So I think it's a wonderful thing to consider. But honestly, dear, I can't think of where I could suggest you might go. Sorry about that. But do it, do it, do it. And you can, whoever that person is, I mean, you can always email me. Remind me that you're the social worker, and I've got a social worker friend that I can put on it. No,
Okay.
he's not a Catholic. He's an Anglican, but he's very, very devout Christian. So,
Yes, or they can send their question to this CWL, and then we can contact you if.
okay, good.
Okay, so that ends our session. Thank you very much. It was wonderful, and it's now that it's on a recording, everybody can go back and look at it, and people that weren't watching tonight, they can watch it whenever they have an hour and a half or so. Thank you, sister. Thank you very much.
Wait a minute. Now I want to end with these two slides.
Okay. Sorry. Okay.
Okay.
Yes.
So remember, we started with Jesus. Always. But when I asked, is there anything special that CWL might be able to do with their history of commitment and care and the like, and so I was thinking that what you bring is women's experience and wisdom. Now, if Jesus in Gethsemane with I don't want to do this, I don't want to do this, that's my favorite for the humanity of Jesus. This is my favorite cure. This is the woman with the hemorrhage. Hey girls, everybody here knows menstrual periods, premenopausal, postmenopausal. Can you imagine bleeding all of the time? And you're not just personally unclean, you're ritually unclean. She couldn't even go to the outer courtyard of the temple, much less the inner courtyard of the temple. I mean, imagine. And she hears about Jesus, and I love this image. This is a famous picture in one of the museums in Rome. She says, if only I'm not even worthy to go ask him, Master, would you heal me? If only I could just touch the end of his cloth. And to me, there's something about women's experience and their interaction with Jesus and Jesus's interaction with women that I wanted to leave you with. So that's my picture. And then this is what I want to leave you with. Again, I want you to ponder with Mary. For Jesus, women are disciples. I mean, I love Pope Francis, love him dearly. He just said women, the diaconate is out. He's wrong. We had women deacons clearly in the early history of the church. I'm sorry, Holy Father, I love you dearly, but I wish you didn't say that. What I want you to, if you look at Jesus, and he's countercultural with children, and he's countercultural with women. I mean, look at him in the scripture. Okay, for him, women, the Samaritan woman. I mean, they got just like the apostles are saying, hey, get the kids away from Jesus. He says, you bring them here. The apostles say, you're talking to a Samaritan. Jesus, do you know what you do? You're talking to a Samaritan woman. Not only did he talk to her, but they have this deep conversation. She, in fact, teaches him something about his scope. And what does she then do? She goes back home again and she tells everybody about Jesus. How about Mary Magdalene? Okay. Who's the one who, in fact, first appeared after the resurrection? Who had to run back, tell the boys what had happened, and the boys didn't believe her. They didn't believe her. So, for Jesus, women are disciples. For Jesus, look at how he responds with compassion, particularly to the issues of women. Peter's mother-in-law, the woman with the hemorrhage, the picture that I showed you, the widow of Nain. I was in Nain. I was on a pilgrimage to the Holy Land, and we went to. I love that. Jesus is walking by, and there's a funeral going on. He says, "What? Who's that?" And he's, she just lost her only son. She has no other children. Jesus has pity on her. I mean, Jesus' response to women and their vulnerability and their sickness is phenomenal. And then this is the third, and I'm leaving you with this. The fact of the matter is, girls, women provide most of the care for sick and dying in the church and in society. Now, I'm not saying we got long-term care. We got a bunch of male LPNs upstairs, and they're wonderful. But the fact of the matter is, if we take the overall, especially in the home, especially in the family, women provide most of the care for the sick and dying in the church and society. They have a lived experience of a good death and the need to support and promote hospice, palliative care, adequate pain control, and attention to the spiritual, refusing to buy into a technical answer to human suffering. God bless.